Well, good morning to all and thank you. So we have been talking a lot about frailty, elderly patients undergoing transplant now, and maybe in continuation of what we have been talking since morning, it would be right to talk about prehabilitation in patients who are undergoing renal and liver transplant. What do we mean by prehabilitation? Prehabilitation is to give a therapy to improve the physical fitness prior to surgery with an intent to improve the post-transplant surgical outcomes as well as recovery. And physical fitness, as we all realize, is two broad terms. One would be frailty, which for most of our patients who undergo solid organ transplants is a very important factor, and cardiorespiratory fitness. And the reason why we think about prehabilitation is because there is a robust evidence in multiple surgeries, whether it's cardiovascular, whether it's abdominal, that prehabilitation definitely improves the patient recovery and surgery outcomes. So what I would be talking in next, say, 15 minutes or so, would be talking as to why we today should be discussing about prehabilitation in solid organ transplants. I would be highlighting, because we have been talking about frailty and sarcopenia, about the role of muscle in rehabilitation, the incidence and the reasons for frailty and sarcopenia in solid organ transplants. Being a nephrologist, obviously chronic kidney disease would be the index case and the index discussion point. And then the effect of these parameters on the solid organ transplant outcome, how to do prehabilitation, and what are still the unanswered questions, and what in my opinion would be the proposed flow of doing prehabilitation and the current guidelines. Well, surgery poses a major metabolic and physiological stress, and it leads to muscle loss and decrease in aerobic capacity to the tune of up to 40%, which might persist for 2 to 3 months. 2 to 3 months. There is also a direct correlation between pre-surgery functional status and perioperative outcome. And as we have been discussing today, we are now encountering more and more medically frail and complex patients, and elderly as well, who undergo solid organ transplants. The skeletal muscle, which forms basically the 40 to 45% of the body weight, is the largest reservoir of protein and is the major buffer against any physiological stress and injury, including surgery. So better the muscle mass, better would be your recovery from surgery. Another very interesting aspect which we don't realize is that muscle is always in a continuous state of evolution. There would be destruction and reformation of muscles. And this is the process which is very well orchestrated, just like any other symphony, and it goes on almost unseen and unheard of. So this cartoon here basically shows the regular muscle turnover in health. It's predominantly run by a healthy mitochondria, which gives you oxygen and ATP. This leads on to the muscle stem cells, which form into muscle fibroblast, muscle myocytes and fibroblast. There is a major role of protein, which leads on to the contractile function of the muscles. As I said, it's a continuously evolving process of destruction and reconstruction. And these peptides are continuously degenerated. And there comes the role of diet in muscle formation. And this diet is closely regulated by hormones we know as leptin and ghrelin. And these stimulate and suppress the appetite. And this protein intake leads on to the continuous muscle turnover. Approximately 280 grams of protein a day is required for muscle turnover only. Now what happens, as I said, predominantly this would be true for all chronic diseases, but more commonly for CKD, and that's what I would be talking about here as well. There is significant mitochondrial dysfunction, less of ATP generation, less of muscle stem cells, muscle fibroblast, and hence you have a whole process of muscle formation which is impaired, and at the same time there is increased protein degradation and increased uptake of protein for the contractile function. And this is compounded further by extremely poor appetite, which could be due to multiple reasons. The important mediators for these mechanisms of decreased muscle mass formation and increased destruction would be caspase 3, inflammation, myostatin, which actually, as the name would suggest, which inhibits the reformation of muscles, which is increased in patients with chronic kidney disease as well as chronic liver disease. And inhibition to ghrelin, which suppresses the appetite as well as increased leptin. So this basically tells us in a very small diagram as to what happens to muscle mass in chronic kidney disease. And progressively with the loss of muscle mass, as you can see in the bottom, there would be less of muscle strength, low physical performance, and finally disability and frailty. So this is a continuum. So muscle mass is the muscle wasting is starting, which then progresses on to sarcopenia and frailty. As highlighted earlier, very few data is available because of multiple definitions which are used. It's important to realize that protein energy malnutrition is one big chunk which would encompass a lot of things. Frailty and sarcopenia are predominantly muscle wasting with a functional component, and muscle wasting would be just loss of muscle protein, which can happen physiologically even under stress. So what is prevalence of muscle wasting in chronic kidney disease? Well, if we look at the global data, in CKD non-dialysis patients, it would be around 11 to 54%. As I said, the definitions vary and therefore the numbers vary depending upon the study population. And in CKD 5D, it would be from 28 to 54%. This is from a meta-analysis encompassing a large number of population. But even in CKD ND patients, we are only looking at 1700 odd subsets, even in a meta-analysis. In the Indian scenario, we have a data from JIPMA Pondicherry, which has told us that in CKD ND, you would have a muscle wasting to the tune of around 69%, and in CKD 5D to the tune of 70%. So just to highlight that around 3/4 of our patient would have significant muscle wasting, whether they are on dialysis dependent or non-dialysis dependent. How does frailty affect the transplant outcomes? They not only lead on to lower pre-transplant physical functioning, and hospitalization, as would be obvious, it also is independently associated with delayed graft function, early and repeated hospitalization, and a higher 5-year mortality. So it's not only that frailty affects the immediate perioperative period, it also affects the graft function and 5-year patient survival. So it's a very important marker if we are able to intervene. Unfortunately, post-transplant, most of these studies have shown ineffective and non-motivation of the patients to undergo or correct their frailty. So the best time of intervention would be pre-transplant, and that's where the role of prehabilitation comes in. So how can we take up rehabilitation? Exercise, as we all understand, would be one very important way of reversing the muscle degeneration and muscle wasting. Exercise would decrease the myostatin expression. It would increase the expression of growth factors. It would increase the muscle mass, decrease inflammation, and it would have some improvement in mitochondrial function. So as I said, all these are important markers which would improve the muscle regeneration and decrease muscle wasting. What is the evidence of muscle exercises or exercise in chronic kidney disease? Well, this is a Cochrane meta-analysis published in 2011, a long time back, 45 RCTs, 1800 patients, and what they found was there was an improvement in global health and physical function. The lean mass of the legs improved only in obese chronic kidney disease patients, and only one study actually had sarcopenic individuals. So this is quite an old data which did show that you would have improved physical function, but still there would be very less objective benefits as far as sarcopenia or muscle mass is concerned. We have more data which is now coming in, especially in our dialysis population. This is again a network meta-analysis of all randomized controlled trials. It basically had 7 studies. It looked at whether you do an intradialytic or at-home exercises. This included giving aerobic, resistance, combined, and inspirating muscle exercises versus the normal activities and exercises at home. And what they found was that either of these modalities can promote benefits for individual in patient undergoing hemodialysis. So whatever type of exercise you might choose, or whether you do it in center or whether you do it at home, dialysis is definitely going to help you in in patients on dialysis. But again, this is not looking at transplant. This is just looking at the feeder population, and that is CKD5D. So this meta-analysis again looks at whether you should be doing resistance exercises versus aerobic exercises. Again, a big fad which is now going on. Again, whatever exercise you might choose to do, it's going to benefit not only in increasing your muscle mass, but also improving your fertility scales. So do whatever exercise your patient can do, at least make them do some form of exercise. It's not only going to improve their muscle mass, but it's also going to improve their fertility indexes. Besides, as was shown in Cycle HD trial, exercise would have multiple other benefits. Most important of them would be the cardiovascular benefits, decrease in the left ventricular mass, and this would subsequently translate into better patient outcomes, cardiovascular outcomes in long terms. So as I said, all this data was predominantly in a population which is CKD5D, a meta-analysis which was including both CKD5D as well as ND. What is the evidence in patients who are likely to undergo renal transplantation? And that is what we are talking about today. That is prehabilitation. Very small trials, 18 patients, of which only 6 were frail. They were advised to undergo 1 per hour weekly exercise in the hospital only. What they showed was it was doable. There was no undesirable effects. 64% had improvement in physical activity at 8 weeks. And importantly, of these 18, 4 underwent renal transplantation. And as opposed to the historical controls, they had lower length of hospital stay. Another small study from France basically looked at 19 patients, 2 per week sessions for 8 weeks. They basically combined endurance, strength, and flexibility training, and they again showed a frailty improvement scale improvement of 15%. Unfortunately, none of them underwent a transplant. We have to realize that these are centers where they would be predominantly taking up disease donor transplants, and they would be looking at only those patients who are seniority on their list to undergo prehabilitation. Another study from China had 42 patients, and again, the only difference as opposed to other trials was that they did a supervised home exercise therapy for 12 weeks. They basically gave aerobic exercises as well as stretching and functional resistance, and there was significant benefit with high rates of completion and patient acceptability. So once we make them and encourage them to do dialysis at home, maybe more patients are likely to take up the exercises. This is meta-analysis which is published for liver transplant patients, and again, small studies, 8 studies, only 3 RCTs, 5 were cohort, and a very heterogeneous population. The exercise and duration were also different, and the sample size or the patient sample size was only from 13 to 33 patients in each study. Variable completion rate of 40% to 90%. Again, the bottom line is no major side effects, significant improvement in their aerobic and physical activity, and one study actually showed decreased post-transplant hospitalization rates with prehabilitation. The other important component of prehabilitation would be nutritional therapy. We all understand that skeletal muscle homeostasis would be better managed with protein supplements. The question is whether we should be giving them oral protein supplements or IV or intradialytic protein supplements. Definitely, oral protein supplements are better. This has been shown in various studies as well as a meta-analysis. Most of these patients were on hemodialysis, a few on peritoneal dialysis, and what they showed was that there was significant improvement in serum albumin with oral supplements, and there was a slight positive benefit on lean body mass, that is the muscle strength. However, again, the studies were small with a very short follow-up period, and there was no hard clinical endpoints and no mention about the baseline muscle mass. So what we are moving now on to is a multimodal intervention, which would not only have exercise, but also nutritional optimization and psychological support. The exercise prescription, again, we have to define a prescription in terms of frequency, intensity, the time, and the type of exercise we want the patient to do. It's not only prescribing an exercise, we have to tell them all these things. We have to also assess the patient's regularity and avoid over or under exercise, and tailor the exercise according to the patient's need and infrastructure. It can either be in the center or during dialysis or even at home. The nutritional prescription can be either an oral supplement after the end of the exercise or in the hospital, or if the patient is unable to feed himself well orally, you can even give intradialytic support. The most important thing, which again the previous speaker also talked about, was the psychological health of the patients. This leads on to non-compliance, increased pain perception, and low functional status. So it is very important to have a good psychologist and a psychiatrist in your team who can have a good thorough psychological assessment and treat depression and anxiety accordingly. These are the current guidelines which were given by the European Society of Organ Transplantation. As I said, there is hardly any data, so they hardly could come up with a solid or a very evidence-based guidelines. They only suggested that solid organ transplant candidates may be offered exercise-based interventions for cardiorespiratory fitness and or inspiratory muscle strength. Underweight solid organ transplant candidates should be offered nutritional interventions, and cognitive and behavioral therapy should be treated for anxiety and depression as a part of prehabilitation guidelines of ESOT. A few unanswered questions still remain. Should we target all our CKD or all our SOT population? Maybe not. We should be looking at the patients who are frail or patients who have a VO2 max of less than 40% of that predicted. So maybe if we focus more on these patients, we would have maximum benefits. The ideal regime, as I said, is whatever the patient can do. It could be either in center, it could be either during dialysis, or it could be home-based, whatever is practical in your setting. The tools for assessment, we have talked in the morning, it's still what is more practical, what you can do easily in your clinic. I find 6-minute walk test and 5 times stand to sit test as a very good practical way. Hand grip, if you have a caliper, is actually quite easy to do as well. So this is a proposed guideline or proposed how to go around prehabilitation in a transplant recipient. This has recently been published in Transplantation. And what they suggest is that before the kidney transplant enrollment or at the time of your kidney transplant enrollment, you should do a proper evaluation. If the patient is non-frail, keep them motivated to be that way. If the patient has intermediately failed, then it's a time to look at the risk factors and treat them, and you have to definitely intervene if the patient is frail. And as I said, repeated reevaluations. What is the prehabilitation policy which they suggest? They suggest an induction policy for 9 weeks, and they have a maintenance till transplantation. As I said, most of these centers are disease donor. We have a better opportunity because we definitely have a date for transplant, being a predominantly live-related program. So 3 hours per week of 2 hours supervised physical rehabilitation, protein supplements during dialysis or after exercise, and psychological counseling. And this can be stepped down subsequently in the maintenance phase. So just to conclude my talk, a large proportion of our solid organ transplant recipients are frail, which adversely impacts their tolerance to surgery. Pre-transplant waiting periods, at least for us, provides a unique opportunity to prehabilitate these patients for improving their peri and post-transplant outcomes. Tailored exercise routine, nutritional counseling, and psychological support are important components of rehabilitation. However, the current evidence is limited, and we can safely say that prehabilitation is safe, tolerable, and has a variable uptake, and we need to have better large randomized control trials to really say what effect it would have in long term. Thank you.